Okay, hello everybody. Let me continue lectures on medical radiology and present you our next topic. We are going down from chest cavity into abdomen, and now we'll observe different diagnostic approaches to anatomy and pathology of gastrointestinal tract, liver and pancreas. First, let me remind you what digestive system consists of. First of all, it's parenchymal organs such as liver and pancreas, and rest from esophagus, next stomach, small intestine, and large intestine, at last rectum are hollow tubes. And of course, different methods of diagnostic are necessary to evaluate properly these organs. Let's observe all of them. Which radiographic techniques may be proposed to study abdominal cavity? First of all, it's study without contrast. Usually it's chest or abdominal X-ray, plain X-ray. Then, if we are confronting with hollow organs, we use contrast techniques. For esophagus, it usually barium swallow, for stomach and duodenum, barium meal, and for colon and rectum, barium enema. Computed tomography or magnetic resonance imaging also may be used with contrast enhancement or without, as you need, depending on your diagnostic tasks. And at last, ultrasound examination. Ultrasound is excellent methods of investigation of liver, pancreas, and gallbladder. It allows to reveal gallstones, focal lesion of liver and pancreas, cysts, benign or malignant tumors, also presence of fluid or gas in abdominal cavity. Its advantage is that it's cheap and always available and very fast. It plays a very important role, for example, even in acute abdomen, when gallstones, which are reason of acute abdomen, and inflammation of appendix may be shown, may be detected on ultrasound scans. But alas, a normal ultrasound examination will not allow you to exclude acute appendicitis, for example. So it should be combined with next techniques, as for example, computed tomography or magnetic resonance imaging. Usually transabdominal approach is used in studying of liver and pancreas, plain or with addition of Doppler technique, which allows to evaluate direction and intensity of blood flow in vessels of liver and pancreas. Contrast studies may be divided on so-called upper gastrointestinal and lower gastrointestinal series. In upper gastrointestinal examination, usually begins with a swallow of barium and takes the picture immediately. And in lower gastrointestinal contrast study, we inflate colon with air and barium and take picture, so-called double contrast technique. Abdominal preparation is needed in radiography of abdominal cavity. Usually it's withhold food for 12 or even 24 hours as needed, and giving enema 2 or 3 hours before examination. Exception is bad condition of patient and suspicion of obstruction, suspicion of acute abdomen. In these cases, of course, abdominal preparation is contraindicated and patient should be taken under X-ray examination immediately without preparation. Here is X-ray film of abdomen, normal X-ray film of abdomen. What can we say about this? Such structures as bone, vertebra, pelvic bones are very good seen on this picture. The rest, parenchymatous organs as liver, pancreas, shadow of liver may be distinct, but not very clearly. Pancreas is completely invisible. Inferior pole of left kidney also can be found, but you will be not sure that it's not mistake. Gas in bowel loops, gas in stomach also may be identified, but impression of uncertainty remains. We can't identify surely where is one or another structure. It looks like this. We may draw contours of internal abdominal organs, for example, stomach and colon, but only just because we know that these organs should be somewhere there, but we can't see them directly. Usually anterior posterior films are performed in abdominal imaging. Right position of patient is necessary. It may include patient from his diaphragm to the pelvic inlet, and exposure is made on expiration. As you remember, maybe on the contrary, chest X-ray are performed on deep inspiration. What can be found on abdominal X-ray in white, bright colors? First of all, it's calcification. Usually these are abnormal structures, gallstones and renal calculi or calcification in pancreas, bones, normal structures, and foreign objects which are, of course, also abnormal. These are examples of calcification, presence of calcification in pancreas and in gallbladder. Some white things, very dense and of course detectable on plain X-ray, may be seen, but pay attention to the fact that organs which contain these pathological structures are not seen. We don't see shadow of pancreas here. We don't see gallbladder itself. We only see calcification in its cavity as well as calcification in parenchyma of pancreatic gland. Foreign objects, different things may be found, and plain X-ray is very helpful in this situation. It fast and reliable, but Alas, we can't also see contours of organs. For example, if we are confronted with the presence of a key in stomach, we detect the key, but we don't see a shadow of stomach, as well as we don't see shadow of upper part of esophagus with squeezes swallowed by a child. Funny sounds may happen. For example, I can't explain you how glass or nail appear in rectum, but alas, these cases happen, not very often, but happen. And also, you may meet forgotten surgical instruments, for example, in pelvic pelvic cavity, how on this picture. Uh, Black things on abdominal X-ray. Uh, Usually it's radiolucent structures, of course. First of all, it's air. And what can we say about presence of air in abdominal cavity? First point, intraluminal gas can be normal. However, intraluminal gas can be abnormal if it is in wrong place, or if too much is of abdominal intraluminal gas is seen. And very important point that extraluminal gas is always abnormal. Here is example of abnormal amount of intraluminal gas in small bowel loops as a sign of small bowel obstruction. Intestinal obstruction may be uh, diagnosed with very simple technique as abdominal X-ray, plain X-ray, and main symptoms of intestinal obstruction are presence of multiply liquid levels in dilated bowel loops and uh, bowels of air above the horizontal levels of liquid in the intestinal loop, so-called Kloiber's bowels. Here are they in white color, and on plain X-ray film multiply horizontal levels of liquid and presence of gas above these levels. What can we say about different parts of digestive tract? Maximum normal diameter of the colon is about 5-8 centimeters. Small bowel is smaller, of course, and should not exceed 3.5 centimeters in diameter. The natural presence of gas within the bowel allows assessment of caliber. Also, the amount varies between individuals. Acute abdomen on X-ray. This, as I have said, simple technique allows to diagnose life-threatening situation without CT, without MRI, a life-threatening situation, for example, acute abdomen. An erect chest X-ray film, not abdominal X-ray, but chest X-ray in is the best projection to diagnose pneumoperitoneum as a result of perforation of bowel and stomach. If your patient is have suspicion for perforation, and if he can stand under the beam during examination, put him under X-ray beam and take X-ray film presence of free gas under diaphragm domes is always pathological, and this problem is surgical. This patient needs urgent consultation with surgeon and maybe immediate operation. Role of abdominal X-ray in the summary. Chest X-ray is very valuable in finding of pneumoperitoneum as a result of perforation, and X-ray, abdominal X-ray made in supine or erect position shows different symptoms of intestinal obstruction. For example, dilated intestinal loops or multiply fluid levels with accumulation of gas above these levels. Also signs of acute abdomen of intestinal obstruction. Contrast agents, very huge topic, but let's try to observe it briefly because it's very important in gastrointestinal studies. Contrast agents are substances used in radiography to increase the contrast of an image, to make normal structures and some lesions look more conspicuous. Contrast agents may be divided on positive and negative contrast medium. Positive absorbs X-ray more strongly than the tissue or structure being examined. It's barium in X-ray or iodinated contrast in computed tomography. And negative contrast medium absorbs X-ray less strongly. Usually it's air as natural contrast. Contrast media is usually specific to the imaging modality and organ. And for all parts of digestive tract, the results of contrast studying should be compared with endoscopic findings. For gastrointestinal tracts, two types of contrast agent are most widely used now. It's first of all simple but irreplaceable barium sulfate, and next generation iodinated contrasts, usually gastrography. What are these substances? Barium sulfate is powder, insoluble powder. It administrated in perils or enema, and after examination leave the body with feces. Very informative, very good contrast agent, but last contraindicated is if perforation is suspected. Iodinated mediums are solution ready for examination. They are water soluble, are given perils or enema for gastrointestinal tract, may be combined with barium sulfate, but it's not always necessary because gastrographin is a very good contrast agent. It itself without barrier. Very important advantage of iodinated contrast agent is their safety in cases of perforation. Contrast agent for computed tomography. Usually low osmolar contrast agent, iodinated and non-ionic solution can help us in enhancing of CT scans. They are administered intravenously. They show rapid exchange between plasma and extracellular fluid. Excretion of this media is performed by kidneys with glomerular filtration or with hepatic cells in cases of renal failure. Contraindications or adverse events, not contraindication, but adverse events of iodinated non-ionic contrast, that they may cause nephrotoxicity and allergic reaction. So before administration, before injection of iodinated contrasts, we need to know about creatinine levels and allergic anamnesis, presence or absence of reactions, allergies for iodinated substances in the past. If you are not sure that administration of iodinated contrast media is safe, if you consider that this administration is contraindicated, refer to ultrasound examination or to MRI. After injection, studying of CT study with contrast divides on several phases. First is without contrast, then arterial phase, about 20 or 30 seconds, when large arterial vessels are contrasted, are enhanced. Next is portal or venous phase, up to 1.5 minutes. It's detection of portal venous system and other veins of abdominal cavity. And next, when glomerular filtration begins, we go through nephrogenic phase. Its duration is about 80 or 100 seconds and very helpful in searching of pathology of urinary system. And delayed phase, about 6 up to 10 minutes, where we observe excretion of contrast agents through ureters and bladder. So if we show on this duration, we should see that whole time for examination is not exceed 15 minutes. It's very fast, of course. CT of abdomen is great at determining any pathology in solid organs of the abdomen. Intravenous contrast of CT in abdominal studies allows to better visualize of blood vessels and solid organs of the abdomen, and Perros contrast enhancement, which is also may be performed during CT scanning, allows to better visualize bowel loops. Bowel loops. Sorry. CT of abdomen, its diagnostic opportunities allows to find free gas in abdominal cavity, fluid in abdomen, all solid organs such as liver, spleen, pancreas, kidneys, and lymph nodes are detectable and in very details, very informative study is CT of abdomen, especially with contrast enhancement with iodinated contrast agents. And so look at the picture and ensure that it's really so. All organs, blood vessels, abdominal aorta, vena cava, gallbladder and stomach as hollow organs, parenchymal organs as liver, pancreas, spleen, everything is detectable. Everything is very good seen. Contrast agents for magnetic resonance imaging. Usually it's paramagnetic agents, gadolinium based. They work not by being radio-opaque, but rather by altering the magnetic properties of nearby hydrogen nuclei, and they enhances the relaxation rates of protons in their vicinity. Excretion more than 90% by glomerular filtration and the rest by hepatobiliary tract. But they are not so dangerous as iodinated contrast for CT studying, and usually cause much less complications. But half-life, look at this, half-life of this agent is 1 hour and a half, and this leads to the duration of MRI examination with contrast enhancement. It's much more longer than CT scanning with also with contrast enhancement. If iodinated contrast agent or CT itself are completely contraindicated, method of choice is administration of paramagnetic agents and performing MRI with this contrast enhancement. Now let's observe different parts of digestive tracts, anatomy and pathology. Let's start with esophagus. The esophagus is hollow tube about 20-25 centimeters long and 2 or 3 centimeters white. Normally, contours of esophagus are smooth and clear. This organ is divided on several sections: cervical, thoracic, and abdominal. We may find three physiological restrictions in esophagus. At the fourth cervical vertebra, it's impression of annular pharyngeal muscle at the level of the aortic arc, and at last at the bifurcation of trachea. Normal esophagus will show you presence of 3 or 4 longitudinal folds. It's normal, and you also will observe peristaltic waves of esophagus at speeds of 2 up to 4 centimeters per second. Of course, a CT is more informative in detection of different parts of esophagus. Different reconstruction in different projections allows us to find all parts of esophagus and allows to estimate how the location of adjacent structures, trachea, heart, vertebra, and so on. Phases of filling and emptying of esophagus on X-ray imaging after barium swallow. First phase is full dilation, or so-called tight filling. After swallow small amount of barium, it occupies all the lumen of esophagus, dilate it, and in this phase we may estimate, we may evaluate size and contours of esophagus. Then constriction starts, and in this phase, in starting constriction, we may evaluate primary relief in upper part of esophagus, and in lower part barium contrast is still present. Then constriction ongoes and occupies not only upper but lower parts of esophagus, and in this phase we may evaluate mucosa relief, 2, 3, 4 longitudinal mucosal fold of esophagus, and complete constriction of esophagus walls, small rests of barium sulfate, and the rest amount of swallowed barium is already in stomach cavity. Here is example of different phases of swallowing and in different projection: tight filling, starting constriction, ongoing constriction, and the same in different projection, as you see. Another picture showing us X-ray of normal esophagus at tight filling In this phase, peristaltic waves may be seen and evaluated, their speed and their completion, and picture of contrasted esophagus at low filling when small folds of mucosa are visible. Well, I believe that demonstration of this short film about barium swallowing was better for you than teacher's explanation. And after this, let's go to esophageal diseases. Here are different most frequent pathologies of esophagus are indicated, and all they all the different pathologies usually present with three group of symptoms. It's chest pain, difficulty of swallowing, and hoarseness. So let's observe some, not all these pathologies, but some of them. Gastroesophageal reflux, very frequent finding in barium swallowing for esophageal examination. It's when barium, which was completely in stomach cavity, appears again in the lower part of esophagus. Usually it's signs of gastritis and esophagitis. Esophageal cancer, challenging problem in oncology, but we should not discuss epidemiology, clinic. We will concentrate only on radiographic features. There are two main types of growth of esophageal cancer. By the way, two main types of growth are also for gastric cancer, for colon cancer, for rectum cancer. These types are so-called exophytic and endophytic. Exophytic type of growth means that malignant tumor grow into the lumen of hollow organ, in this case in the lumen of esophagus. And endophytic when a lesion occupies all the circumflex of digestive tube and forms circular narrowing. Circular narrowing is the science of endophytic types of growth, and filling defect, erode. There are no barium. Here is place of tumor which is coated by barium sulfide. And in the case of endophytic lesion, barium can pass through the narrowing, and there are absence of barium substance in affected part of esophagus. All this, as I have said, previously always combine radiological findings. It may be filling defects, maybe narrowing doesn't mean all pathology found on X-ray or on CT compare with endoscopic findings. CT for esophageal cancer is of great diagnostic value. It allows to find not only primary tumor but to estimate its invasion in adjacent structures, affection of regional lymph nodes, and many other things. If your hospital is may allow to provide nuclear medicine techniques, don't forget about positron emission tomography examination, which may show pathologic accumulation of radiopharm substances, radiopharmaceuticals, and CT combined with positron emission tomography will show you where the pathology is, its localization. What about stomach? First of all, its size and position vary depending on constitution of patient. Here are variants of gastric position. Most frequent are presented in. You may conclude that this position in normostenic is not the same in hypostenic, and in asthenic persons it also differ. Different parts anatomy. Short reminder about anatomy of stomach. All parts, fundus, body, antrum, two curves, lesser and greater, pylorus, gastroesophageal junction. All these parts will be visible in CT films, in X-ray films, in MRI imaging, everywhere. The important point is the thickness of stomach wall. It varies depending on its stretching. On CT, for example, with a sufficient amount of fluid taken before the study, usually patient is asked to drink water before CT scanning. It should not exceed 10 or 12 millimeters. X-ray examination of stomach can show us morphological and functional characteristics. Morphological characteristics are form, dimension, position, contours, relief of mucosal fold of stomach, and functional characteristic also very important is motility of organ or motor function, and evacuation, complete or incomplete. Here is X-ray film, plain X-ray film of stomach at tight filling and at low filling. Let's repeat that tight filling is for evaluation of size and localization of organs and of its contours. and low filling is for estimation of mucosal relief. On these two X-ray films, image of stomach is without mass, obstruction or filling defects. Gastric disease. Three most frequent pathologies are ulcer, cancer, and pyloric stenosis. Signs and symptoms are also common, uh, are also similar as in the case of esophageal pathology and include pain, anemia, hematemesis or melena, emesis, and weight loss. First pathology which we will observe is ulcer of stomach. This defect, ulcer defect with barium study will be contrasted directly by barium sulfate and will show us two symptoms depending on localization of ulcer. If ulcer is located on small curve, as in this case, we will observe so-called symptom of niche on the contour, and if ulcer is on the anterior or posterior wall of antrum, as in this case, picture of niche on relief will appear. Both are symptoms of benign ulcer, and for example, here is example of niche on relief, and this picture shows us niche on the contour. Here is benign gastric ulcer, and as we have said, for esophageal pathology, combination of endoscopic techniques and X-ray studies is very useful, and direct sign of gastric ulcer is crater filled with barium sulfate. Also may turn into malignant growth, and differential diagnostic of malignant and benign ulcers is very important. Usually, irregularity of contours, tendency to rapid growth, changes of mucosal fold near the ulcer are signs of malignancy, and on the contrary, smooth regular contours and relatively small size, not enhancing during several examinations, shows us benign gastric ulcer. Gastric cancer. The most early sign of this pathology is the restructuring of the relief of mucous membrane. All the rest appears later, but first of all, we observe loss of normal mucosal relief in affected part of stomach. Later signs are filling defect without regular contours, loss of folds, rigidity of walls, absence of peristaltics, and narrowing of affected part of stomach. Here are examples of two types of gastric cancer: gross exophytic and endophytic. As in the case of esophageal cancer, also exophytic type of growth, filling of defects, and endophytic circular narrowing in the terminal part of esophagus, as on this picture. CT allows, of course, X-ray film is not enough, even when confirmed by biopsy, by endoscopic study, is still not enough to complete evaluation of gastric cancer, and for correct staging, advanced gastric cancer needs to be confirmed by CT examination. On CT, primary tumor, its relation to adjacent structure, signs of invasion of adjacent structures, status of regional lymph nodes, everything is maybe taken from CT pictures, and everything is necessary for correct staging of the disease. Regional and distant lymph nodes are very important in decision about treatment. Status of lymph nodes is very important in making decision about treatment of gastric cancer, and on plain X-ray film lymph nodes are completely invisible. On CT, you may observe him very clear. Colon pathology. Here is a picture showing us colon with after barium enema, then after evacuation of barium with feces, and inflation of air after this. The rest of barium and presence of air in the colon forms a picture of so-called double contrast study for rectum and colon. What about normal colon anatomy? I don't think that its length is important. Thickness is more important, as I think. Normal thickness of colon wall is about 3 millimeters. Of course, it may be not evaluated, it may be not measured on X-ray films, but only after CT scanning, desirably with contrast enhancement. Diseases of colon: appendicitis, diverticulosis, polyps, cancers, enterocolitis, hemorrhage, and symptoms which may be found in patients with colon problems are presented here, and let's look through it very quickly and focus on certain pathologies, different pathologies of colon. Acute appendicitis. Do you remember that we have said about possibilities of ultrasound in detection of acute appendicitis, and we said that only ultrasound alone may be not enough, and diagnosis should be confirmed by CT scanning. In acute appendicitis, CT allows to detect distended appendix with local inflammation. Of course, don't forget about clinical symptoms. Local pain, increased white blood cell count, and so on, so on. Abscesses of abdominal cavity and role of CT in it. It can't be overpriced. I think CT is very reliable in detection of abscess, of fluid, presence of fluid and gas into abscess cavity, and also evaluation of treatment procedure. For example, here catheter has been placed by radiology using CT guidance, and in order to drain abscess and collection of fluid from this abscess, not fluid, pus. Colon cancer. Next challenging problem, radiological methods of examination are combination of X-ray and CT, and both these techniques shows us so-called apple core symptom. Apple core type of constricted lesion with proximal dilation of colon. It's relatively with thickening of colon walls. It's relatively good confirmation of colon cancer diagnosis. Of course, you may perform biopsy from this area, from this lesion, and confirm diagnosis morphologically, but today we are concentrating only on radiological science. So different parts of colon cancer in these different parts produces the same apple core symptom as usually on X-ray films and on CT scans. Another example of colon cancer, affection of ascending bowel. Here you see that no contrast media, no barium sulfate is present in ascending colon, because the lumen of ascending colon is occupied by malignant tumor. The same in rectosigmoid cancer, persistent irregular circular constriction of rectosigmoid part of 4 or 5 centimeters length with irregular and indistinct outlines. Flow of contrast media above restricted is violated, and in the lesion walls are narrowed and rigid. Folds of mucosa in the area cannot be seen. Rectal cancer. The same symptoms as in colon cancer, thickness of wall and circular obstruction of rectum lumen. Normal thickness of rectum wall on CT should not exceed 10 12 millimeters, and thickness of wall, if it is good delayed by air insufflation, thickness of wall is very suspective in colon cancer diagnosis. Benign pathology of colon and rectum. First is polyps. Polyps on wall is benign tumors which grows from mucosa into lumen of rectum or colon, and in X-ray examination after enema, these lesions are coated by barium sulfate, are outlined in this way by barium sulfate, and shows us location of this pathology. Usually it is occasional finding and needs no treatment. Diverticulosis, on the contrary, situation when barium extends from lumen with mucosa, extends from lumen outward colon wall, and barium will accumulate in the diverticulus cavity, and may be found as such symptom on plain X-ray films. Pancreas imaging. Three most important modalities. Simple X-ray, you may read about it on this picture, but it's of no value. Ultrasound, CT, and MRI. Each of them, and most of all combination of them, will present you a very clear picture of pancreas. I will not read all this text. You may conclude that ultrasound, CT, and MRI are methods of choice for examination of parenchymal organs, and of course they should be chosen for examination of pancreas. Pathology of pancreas. Pancreatitis occurs when digestive enzymes produced in pancreas become activated not in lumen of intestine but inside the pancreas, causing the damage of the organ. Acute and chronic pancreatitis, again, only radiological signs in acute pancreatitis. Nothing specific, only diffusely enlarged hypoechoic pancreas, combined with clinical symptoms, pain, and so on. Only enlargement of pancreatic parenchyma in cases of acute process, and in chronic cases there are several symptoms: alteration in size, glandular shrinkage, parenchymal or ductal calcification, dilatation of pancreatic duct. Dilatation of the pancreatic duct is most specific symptom. Usually in normal diameter of pancreatic duct does not exceed 2 or 3 millimeters. If greater, it may show the presence of chronic pancreatitis. Appearance of chronic pancreatitis on chest X-ray or on abdominal X-ray film, conventional X-ray film shows multiply calcification of pancreas. CT in patient with chronic pancreatitis shows significantly delayed main pancreatic duct, black arrow, and this duct is surrounded by much smaller in size atrophied pancreatic parenchyma, indicated with white arrows. Pancreatic cancer. Diagnostic methods of choice are ultrasound and CT with bolus contrast enhancement. It allows to visualize not only the incidence of the primary tumor mass, but also to evaluate the presence of metastasis, invasion into adjacent organs, or comorbidities. Laparotomy with biopsy may be used for diagnostic purposes, and it was usual approach in previous years, but now after appearance of CT, biopsy under CT or ultrasound control is preferable. Here you see that fine needle was injected into tumor lesion, into pancreatic head in this case, and sample will be taken for cytological or morphological examination without operation. Very fine and very informative and reliable technique. Here is only example of next example of tumor of head of pancreas. Its localization and structures that may be distinct at the same level, at the level of the tumor, gallbladder, liver, and mesenteric vessels, arteria, and vena. Liver, the last organ we will observe. Usual techniques for its examination are ultrasound and CT scan. Signs of normal liver on ultrasound scans are homogeneous echo texture. It has a hypoechoic appearance when compared with the spleen, and slightly hypoechoic or isoechoic to the renal cortex. On CT scan, structure of normal liver is homogeneous with attenuation values ranging from 40 to 60 Hounsfield units. Liver diseases, diffuse and focal. Diffuse are results of inflammation, of disturbances in metabolism and in morphological changes. Hepatitis, steatosis, and cirrhosis. Focal, cysts, abscesses, and tumors. Hepatitis, no pathognomical radiological signs. Ultrasound, scintigraphy, nuclear medicine, other methods of nuclear medicine, for example, PET, but no need of in PET in hepatitis. CT will show only increase in size and heterogeneity of organ. Splenomegaly also may be present. Don't forget about clinical symptoms. Don't don't forget to look for bilirubin levels to confirm the diagnosis, but nothing specific in a structure of organ except its enlargement, diffuse and huge enlargement you will not find in case of hepatitis. Steatosis, or so-called fatty liver. Uh, Disease is caused by diffuse infiltration of the liver cells with natural fat. Let's not focus on the reason of this process. Uh, it's chronic alcoholism, nutrition problems, obesity, and many others. Uh, uh, Radiological signs. Ultrasound shows us uniform increase of the liver, diffuse increasing of its heterogeneity with preservation of uniformity. It's the picture, ultrasound picture, is not heterogeneous. CT scanning. Diffuse decrease in densimetric parameters of liver parenchyma may be found. Two values lower than 25 Hounsfield unit. It's lower than normal hepatic cells, and sometimes even to negative values corresponding to density of fat. Usually a little enlargement of organ is seen. Cirrhosis is significant decrease in number of hepatocytes, progressive fibrosis, and portal hypertension. Signs of cirrhosis, radiological signs, is liver enlargement, its age is irregular, heterogeneity of structure, splenomegaly, and portal hypertension as a result of dilatation of liver vessels and esophageal varices. Here are two pictures show you examples of cirrhosis combined with ascites as the result of portal hypertension and deformation in a deformed, irregular wrong contour of liver and heterogeneity of liver structure as a result of development of connecting tissue. Focal diseases of liver. First of all, tumors. Ultrasound, CT, and MRI, alone or in combination, will present areas of unequal density with irregular contours. Examples are hepatocellular carcinoma, its primary tumor of hepatic cells, and liver metastasis. Liver metastases usually are multiply. Hepatocellular carcinoma is unicentric usually. Liver metastases are usually multiply foci of different size, usually hypodense. MRI of liver in suspicion of metastasis is also of great value, but should be always performed with gadolinium enhancement. You see that MRI picture without enhancement shows us nothing special from the liver, but after gadolinium injection, enhancement of huge lesion at the border of left and right lobes appears visible. Hemangiomas, hepatic hemangiomas are most benign liver tumors. On non-enhanced CT may be found as hyperdense masses. Usually, hemangiomas shows no difference between arterial and venous phase of contrast enhancement, and only in delayed phase maybe on the periphery of the lesion may appear small nodular or globular areas of enhancement proceeding towards the center. As in this case, these small things are signs of enhancement, contrast enhancement, and here is a shadow of artery which is supplying hemangioma. What is the nature of liver hemangiomas? They are a disorganized collection of blood vessels within the liver. Usually they do not cause symptoms unless they get very large, very huge. Usually they are occasional findings and needs no treatment. They don't really have a appreciable risk of converting into cancer. Typically, they are just observed unless they are massive or symptomatic. If it meets classic criteria for hemangioma, you don't even really need to get repeat scans to evaluate the dynamics of the lesion. Cysts, liver cysts, focal pathology of liver, it's formation in the liver of the cavity or multiple cavities filled with fluid. Cysts develop from rudiments of bile ducts and turn into a cavity lined with epithelium from inside, which produces liquid. Cysts appear on CT scans as small, large cavities fulfilled with fluid, and density of fluid differs from the density of surrounding liver parenchyma with parenchyma of spleen at the same level of examination. Density of fluid, density of water may be measured, and if it is about 0 house-filled units, you may say that you have confirmed diagnosis of cysts, and of course smooth and regular contours. Tendency of growth maybe if epithelium which cover cavity of cyst from inside continue to produce liquid, it may lead to increasing of size of cyst, but symptoms usually it's asymptomatic. Abscesses, another example of focal pathology of liver. confined collection of pus in destroyed hepatic parenchyma as a result of penetration of pathological flora or parasites from the ascending biliary infection, hematogenous spread to the portal venous system, or via the hepatic artery in sepsis. Abscess of liver, in contrast to cyst, has irregular contours, uh, heterogeneous structure, densimetric densitometric density is higher than in cysts, and usually, of course, they are combined with severe clinical symptoms, fever, change in blood count, and so on. Another symptom of liver abscess may be formation of accumulation of gas in its cavity as a result of destroying of abscess substances. Here is a level, horizontal level of pus and gas under, oh no, sorry, upper the level of pus. Ascites, radiological features of this pathology. Plain X-ray film usually are of no use. CT may show fluid collection in abdomen with considerable accuracy. This fluid appears anechoic. It is freely mobile, and bowel loops may be seen floating in the fluid. Under ultrasound control, ascites or abdominal effusion can be aspirated for diagnostic purposes, and in order to put drainage by means of catheter also can be undertaken. CT, as in many other cases, more informative, more reliable technique demonstrates ascites as a low-density margin around the intra-abdominal organs and is most clearly seen adjacent to the liver, for example, as on this slide. So, thank you for your attention.